Это честь большая представить Зарка Альферевич в Украине. В свое время Зарка именно был тем человеком той команды, которая перевернула представление и подходы медиков, акушеров, перинатологов повсеместно по всему миру. Вообще вот это влияние на медицинские практики очень трудно переоценить. Его работы, его обзоры, метаанализы относительно практик в антенатальном уходе, в ведении родов, что касается различных акушерских подходов. Все поменялось, как вы помните, около 10 лет назад, благодаря именно работе Cochrane Collaboration. Зарк Альферевич сегодня представит подряд две лекции
In Croatian we say dobro jutro. I have two talks to give. One on induction of labor and the other one preterm birth. One of the slides will show so if I speak too much then just stop me and hopefully you will be okay. I feel sorry for our translator. He will have to work very hard this morning. Right. I was asked by Victor to talk on induction of labor, and I can tell you a little bit of our experiences, a bit about evidence, and also some of our experiences in Liverpool, where I work. The reason why induction of labor is a very important topic for us is because we do lots of them. I'm sure you're going to be horrified to know what our percentage of induction of labors are in Liverpool. This is our every year from now on we publish national data for several key outcomes or performance indicators of preterm birth for each hospital. They are publicly available. So our hospitals, so patients can actually see what the outcomes are in our hospitals. And here I have presented for you the national spread of frequency of or percentage of labors that are being induced in each hospital in the country. And you will see that national average is around 29% inductions. But my hospital, Liverpool Women's, and we have 8,700 deliveries per annum, has 39% induction. So we are a huge outlier. And the reason why we do that, our explanation is because we are evidence-based hospital, and then there are a lot of trials that have shown that in a high-risk situation, like gestational hypertension or mild preeclampsia, or intrauterine growth restriction, small for gestational baby at term, it is reasonable to induce labor. And these inductions do not increase cesarean section. Our population around Liverpool is quite poor, and therefore our problem of making sure that women come regularly for the follow-up at term, rather than asking them to come every other day for CTG or for monitoring, we give them a choice of being induced, and they take it. What we haven't done yet, we haven't been offering induction of labor to low-risk women routinely. But now you have heard Jerry Visser talking about this recently reported study which 10 years ago I would have thought was completely crazy, where they have offered in United States, in 41 hospitals across the United States, they have offered induction of labor and to low-risk women with no complications, and shown that, if anything, there was slightly less cesarean sections in women who were induced. There was significantly less preeclampsia. And also, if anything, there was slightly less complications when it comes to the baby, perinatal complications. Now, that is something completely opposite to what I was teaching medical students and my junior doctors for last 20 years, because I was telling them that inducing labor unnecessarily is dangerous and increases cesarean section. Now, here is the evidence to suggest that I was wrong. Now, we have in our country where I practice in United Kingdom, we have a national guidelines. So when there are important topics, then National Institute of Clinical Excellence gathers the group of experts and with independent chairs, and we spend a lot of time gathering the evidence and arguing, trying to produce a national guidelines, which, at least in theory, then everybody is supposed to follow. One such guideline is induction of labor, and I was part of the committee that was putting them together. And I'm just going to give you a few highlights. That there were a lot of things that we disagreed on, but there are some that we have agreed on, and those are the ones that really were not controversial, like that health professionals have a duty to explain to women reasons why we believe that induction should happen. We should explain clearly when, where, and how it should happen. We should explain what available support and pain relief is going to be available for women who need induction, and also explain what would be the alternative for women who do not want to be induced, and also what is going to happen if our induction is not successful. And it often, I find it upsetting how many women who, when they start induction, when I ask them, were you told what is going to happen if induction is not successful? They said nobody told us that induction cannot be successful, despite the fact that we know that at least 30-40% of women are not going to be in labor after 24 hours. Okay, so what our national policy is that at 38 weeks, all women should be offered information about the risk associated with pregnancies that last longer than 42 weeks. In other words, around 38 weeks, we need to prepare them for the possibility of post-term pregnancy. In our country, we are talking about membrane sweeping, and we are saying that membrane sweeping should be offered to prevent preterm birth. I don't know how do you call that in Ukraine, and whether you do that. You do membrane sweeping? Okay. Not every woman is going to want to have it, but it is our duty to offer it. It is also a recommendation that every woman with uncomplicated pregnancy should be offered induction between 41 and 42 weeks. We have spent many, many hours arguing whether it should be at 41 weeks, term plus 10, and 42 weeks, and we couldn't agree. So what we said, any time between 41 and 42 weeks is okay. It's up to you to decide when you want to offer it. And therefore, the exact timing should take into account women's preferences and also your ability to actually do it. In my hospital, because we have so many inductions, it's not easy for a woman who says, I want my induction tomorrow, and then we say, yeah, but we haven't got any space to do it. So that's not as easy for us as it should be. And the reason for that is well known to you, and I don't have to dwell on it, because there is this exponential rise in a risk of stillbirths, but the numbers are quite small. So actually, when you, in a Cochrane review of stillbirth prevention by term inductions, if you look at all these diamonds, they are all fairly similar. There is no question that induction at any gestation after 37 weeks reduces the risk of stillbirth. That is common sense. The problem is that number of inductions that we need to do to prevent one stillbirth. And on average, you're looking at nearly 400 inductions to prevent one stillbirth. So you could do it the other way around and say that, yeah, we will be probably doing 368 unnecessary inductions to prevent one stillbirth. There are, of course, you all experienced obstetricians. I'm not going to talk about reasons to induce ruptured membranes, postpartum pregnancy, IUGR, small baby, big baby, and you know we can talk about all of these. Some of them are common sense, some of them may be controversial. But I want to now spend some time talking about when you have made a decision to induce labor, how should we do it? Now, in our national recommendations, we have made a clear recommendation that preferred method of induction should be a prostaglandin E2, vaginal dinoproston, regardless of cervical status. Unless, of course, there is a high risk of uterine hyperstimulation. Now, some have interpreted this that if woman is multiparous with a cervix that is favorable, that a risk of uterine hyperstimulation in this instance would be high enough to justify a rupture of membranes and oxytocin. But certainly in my hospital, we would not start oxytocin and ARM without prostaglandin first, unless woman is, of course, 3 or 4 centimeters dilated. Now, we have, so that is currently NICE guideline recommendations. But my team has carried out and published a systematic review and network meta-analysis and cost-effectiveness analysis of all randomized controlled trials that have tackled the issue of induction of labor. In that really big piece of work, we have included 611 randomized studies, and with 31 different methods of inductions. So we have done quite complex statistical analysis trying to find out who would be the winner when all these data are somehow reanalyzed. And there are some striking findings that I'm going to summarize from this paper. Intravenous oxytocin with amniotomy and vaginal misoprostol were most likely to achieve vaginal delivery within 24 hours. So they are kind of most aggressive way of, and the fastest way to achieve labor. Now, if induction of labor was all about effectiveness and speed of which labor can be achieved, then those would be your winners. However, we also need to be conscious of safety and other outcomes, not just how fast induction is. So therefore, for example, with low-dose oral misoprostol, the cesarean section was the lowest. Vaginal and sublingual misoprostol were most likely to cause uterine hyperstimulation. Unfortunately, we didn't have a good data to talk about neonatal mortality and serious morbidity, partly because these outcomes were very, very rare. So it was not possible to make a differential comparisons between the most of these studies that would be statistically robust. When we consider the price of these methods, the overall conclusion was that there was a considerable uncertainty in estimates, but titrated low-dose misoprostol showed the highest probability, and sublingual misoprostol showed the highest probability of being most cost-effective, therefore putting together effectiveness, safety, and the price. The problem, of course, is that it is not quite clear how this oral misoprostol should be used, because people have used different protocols, whether it should be tablet or solution. Not quite clear how exactly we should titrate, and also whether it should be the same protocol for primips and multips, and whether if you start inducing with low-dose oral misoprostol, is it okay to carry on until woman delivers, or should we actually, in active phase of labor, swap to oxytocin? Now, so at the moment, in my hospital, you will see we are still using dinoproston mainly, but we have actually swapped to a low-dose misoprostol in a different form that I will tell you about our experience recently. So we are still sort of sitting in between vaginal dinoproston and low-dose misoprostol. Now, one thing that is now very fashionable in my country, and I don't know whether this is something that you have started to do in Ukraine here, and those are outpatient inductions, meaning that we start induction in hospital and then we send women home. Now, 10 years ago, I would have said that this is absolutely crazy practice, and I would never even contemplate of doing such thing. But slowly and surely, more and more women were asking for it. Some brave doctors have started to publish some evidence in favor of it, and gradually we are coming around and start thinking about outpatient induction, because we have so many in hospital that the concept of sending women home to labor slowly and come back to us in active labor is potentially quite attractive. We have done a Cochrane systematic review looking for pharmacological and mechanical interventions for labor induction, and we identified 34 studies with 11 methods that have all been tried in outpatient setting. And the conclusions that we drew is that induction of labor in outpatient setting appears feasible. It is possible to do it. But in these studies, we did not have enough evidence to be able to say which of these methods is the best, safest, and most effective. So basically, what we said, over to you, and keep doing the studies, keep gathering the experience until we decide what is the best way to do it, if at all. And therefore, NICE guideline in a previous guidelines have said that induction of labor in outpatient setting cannot be recommended because there was not enough evidence. But now we have added that women can have labor induced at home, but only if the clinicians are satisfied that safety and the support procedures, including regular auditing of the data is in place. Now, people have been worried about prostaglandins in outpatient setting because of hyperstimulation and fetal distress. So therefore, there has been suggestion that the best way to do it, to induce labor in outpatient setting, is to use intracervical catheter, and there has been recently a review of the side effects and problems, potential problems with Cook catheter. And this systematic review identified 26 studies with more than 8,000 women induced by Cook catheter, and showing that actually adverse events are exceedingly rare in induced labor. And therefore, they concluded that this study suggests that the risk, not only that the risk of adverse events during period between insertion and expulsion of the catheter is very low, and therefore that this low-risk procedure can be potentially suitable as in an outpatient setting for low-risk pregnancies. The problem is that we do not have enough randomized controlled trials yet. So, presented with all this evidence, in my hospital and with such a high induction of labor number of women, more than 3,500 women we induce every year, we have now come up with a protocol, and this is the protocol that we have just agreed and we are currently implementing, so that in women with intact membranes who are low risk, we use slow-release dinoproston, the tape with dinoproston that slowly releases it. We call it a Propes. I hear that you have here intracervical Prepidil as a one-off. We are now using this slow-release dinoproston, and if you have intact membranes and you are low risk, we're offering to send you home. If you are high risk, we use a slow-release tape coated with misoprostol, and we do that in hospital. With ruptured membranes, we use slow-release dinoproston both in home and hospital. And for women who have a previous cesarean section, if they rupture the membranes, we use oxytocin. And if they are low risk, we use, or high risk, we use a Cook catheter. And yes, we are one of these crazy people who do induce women with a previous cesarean section. This is those are these tapes coated with either dinoproston or misoprostol. And this is a description how you, with fingers, hook it behind cervix and use it for induction. And I have some data to show you, which haven't been published yet. They are literally, we have put them together for this talk. We have compared our dinoproston gel that we used to use, misoprostol slow release, Misodel, that we are using in hospital, and dinoproston slow release Propes that we are using for women at home. And you can see that there are not a lot of differences, that probably dinoproston slow release is the slowest, but we are fine with that because this is the one that we use at home. That misoprostol is the most aggressive because we use terbutaline tocolytic quite a lot because women are hyperstimulating, but when it comes to cesarean section rate and use of epidurals, or what we call category 1 cesarean sections for acute fetal distress, there are not that much of differences. And in terms of ABGA score at 5 minutes, the numbers are okay. So we are continuously auditing our data, and what we are seeing that using Propes or dinoproston slow release in a carefully selected patients at home, and misoprostol in hospital appears to be working for us. But we will continue to collect the data and hopefully publish them regularly. So in summary, dinoprostol, low-dose misoprostol in a slow-release form, certainly in our experience, are reasonable, and intracervical catheters are also reasonable choices for labor induction. We believe that outpatient induction is not going to go away, and I would be interested to see whether you do it and whether you have any experiences here in Ukraine with outpatient induction, and what are your thoughts on it? Because, as I said, this is a really hot topic in my country, and the key question, the key issue is that we need to keep reviewing and see whether there is at least some consistency between them, and we decided to systematically go through them and to identify the areas where clinical guidelines, international clinical guidelines, agree. Because my personal view is that it's absolutely crazy that every country, every hospital these days has to publish their own guidelines. So there are so many of them, and we waste so much time and effort and money sitting around the tables agreeing and disagreeing on the guidelines, that surely there must be a better way of sharing the information. And I don't understand why the clinical guidelines in Ukraine should be significantly different from clinical guideline in UK when we are all looking at exactly the same evidence. So anyway, we went through 750 what we thought could be relevant guidelines. We have identified 49 guidelines from 16 groups that satisfied our quality criteria, and here you can see a lot of them. Most of them are national bodies who have produced the guidelines on management of preterm birth, and we have lumped the recommendations under the heading of screening, and when you look at all these 49 guidelines, we could identify only 2 issues where only 2 screening programs where majority of guidelines agreed that this is a good thing to do. And that is cervical length screening in high-risk women and screening for asymptomatic bacteriuria. When it comes to medications, most of the guidelines agree that tocolysis up to 48 hours is a good idea, that magnesium sulfate for neuroprotection is a good idea, that antibiotics for pre-labor, preterm rupture membranes is a good idea, that vaginal progesterone for very short cervix before 24 weeks is a good idea, and that, of course, antenatal corticosteroids is a good idea. Do you agree with that? We can talk about it. When it comes to surgery, most international guidelines agree that elective cerclage is a reasonable idea when you have at least 3 pregnancy losses. That cerclage with the cervix before 24 weeks with previous preterm birth is a good idea. And also that transabdominal cerclage is a good idea after vaginal cerclage failed. Now, in my country, we have so-called specialist preterm labor clinics. So women who have a previous preterm birth tend to come to a designated specialist clinics where we look after them. And we asked these specialist clinics to tell us what they do, what type of patients they see. And indication for referral to such a clinic is previous preterm birth or previous ruptured membranes, and or significant cervical surgery or recurrent second trimester loss. And majority of these clinics are only going to accept patients if this preterm birth or ruptured membranes happened before 34 weeks, not before 37 weeks, because there are too many of them and we can't cope. What do we do in these preterm birth clinics? Of course, we use ultrasound, and you know about cervical length measurements. In my preterm birth clinic, we tend to use gestational age corrected cervical length, and those are the charts that we use from that have been produced by Salomon at group and his group in France, and we have validated them, and the distribution of cervical length in a low-risk population in France and Liverpool is the same. So we accept that cervix shortens in pregnancy, and therefore we feel that, like we don't use a one cutoff point for BPD or abdominal circumference in pregnancy, we should treat the cervix the same and use cervical length gestational age corrected. And then, of course, when you have something like this is bad. And of course, based on this, we can actually estimate the risk of preterm birth for high-risk women. Now, increasingly, cervical length can be combined with a fetal fibronectin, and it is now possible to actually objectively quantify the risk of preterm birth. And if, for those of you who have apps and iPhones, you can actually download this Quip app free of charge that allows you to combine woman's history, cervical length, and quantitative fetal fibronectin, and give you the risk of preterm birth for each individual woman if you put in cervical length and fetal fibronectin values. The question for us as a clinicians is, once you have got your, unless you know or you have some idea what would be risk, what is the cutoff for the risk that you want to treat. But it's not just an absolute risk. It's also what drives this risk. What sort of, and as you know, clinically, there are so many clinical scenarios that also may influence your decision. You know, is this short cervix after routine scan, fibronectin positive? But you may say, it doesn't matter to me what is the clinical scenario. If, irrespective of clinical scenario, if the risk is 20% of preterm birth, I'm going to treat. The question is what you're going to treat with. You can use Seclage, progesterone, pessary, Arabin, or I've just learned from Victor that there are some other forms in Ukraine that you may want to be using. You may want to put a woman on a bed rest, or you can simply just give steroids. I'm just going to give you certainly my interpretation of the evidence as it stands at the moment. In singleton pregnancy, in UK, still to this day, the most common procedure seems to be cervical Seclage. There has been a large study published by Kypros Nicolaides and his team, where they screened 47,000 women, 470 had a short cervix, only small minority had a previous preterm birth, and they published it in the Lancet and basically concluded that cervical Seclage is not a treatment for short cervix if you found it on a routine second trimester scan. Now, subsequently, Americans have done a randomized control trial And they have shown that in 300 women with singleton pregnancy with a previous spontaneous preterm birth, this high-risk situation, that of which there was only 12% in a Kyprosis study, that particularly when the cervix is very short, less than 15 millimeters, there was a benefit of a cervical cerclage. We have done a Cochrane review trying to put all these together, and the question that we wanted to ask, is it really true that cerclage works only in a subgroup of high-risk women with a short cervix? And when you actually compare the results in a cerclage that is history indicated, a cerclage that was driven, like in Kyprosis study, by one-off ultrasound in a general population, and also in a serial ultrasound cerclage, indicated cerclage in high-risk women, like in American study, that actually the results are quite similar, and that there is no evidence of differential effect in any of these subgroups. The only difference is that numbers needed to treat is somewhat different. So, if you have a short cervix in a high-risk clinic, women with previous preterm birth, then there is only around 11 cerclages that is needed to prevent one preterm birth. Now, if it's only based on history, then there is a 24 cerclages, so you need to do more, and because this is a slightly lower risk. And of course, in a short cervix that is found on a routine scan, again, around 22 cerclages. So stitch works in all of these groups, but the number needed to treat is somewhat different. The key question is progesterone better than a stitch when the cervix is short? It is important to be clear that we are talking about two different progesterones, and certainly I think that there is now, certainly to my mind, enough evidence that 70-hydroxyprogesterone caprate is inferior as a treatment to a vaginal progesterone. So certainly in UK, virtually nobody uses it, and I think that even Americans are now slowly coming around and shifting from 70-hydroxyprogesterone to vaginal progesterone, and here is Vincenzo Berghella, one of the probably most prominent researchers, American researchers in the field of preterm birth, conceding that time has come probably to shift to vaginal progesterone. Now, the problem that we have in my country, that we did a large national study called Optimum, that concluded that vaginal progesterone was not associated with reduced risk of preterm birth and no long-term benefit, but it wasn't specifically targeting short cervix. So when Roberto Romero and his team carried out a updated systematic review, including Optimum results of only women with a short cervix, they concluded that actually vaginal progesterone may not work for everybody, but for short cervix, it does work and probably has the most pronounced effect, which was confirmed in a network meta-analysis by Jarde and his team, multi-center study where they compared not only progesterone and cervical cerclage, but also included data on Arabin pessary, and suggested that when you look at indirect comparisons, that progesterone is probably the data in favor of progesterone are the strongest. So it is quite interesting that despite of all the evidence favoring progesterone, vaginal progesterone, certainly in UK, in specialist clinics, cervical cerclage seems to be still the most used treatment, because we obstetricians we like surgery and we like doing things, and we feel that kind of like we seem to be emotionally attached to stitch. Arabin pessary, most of you will be familiar with a study that basically kicked off this whole issue of Arabin pessary for preterm birth prevention, although Bin Arabin and some people in Germany have been using it for years and years and years, but they never had a good quality studies to prove what they felt until people from Spain took up the challenge, did a randomized controlled trial, and showed absolutely extraordinary results that were unfortunately not replicated very often. And now we are still a little bit in the dark because, as you can see here, we have a study by the Spanish study showing a phenomenal benefit, and then we have subsequently 2 negative studies. So therefore, pulling them together doesn't make much sense when they are so vastly different, and you can actually look here that heterogeneity between these 3 studies are just too much. So therefore, rather than pull them together, we need to try to understand why are they so different. We have carried out a non-randomized comparison looking at the results from my clinic, where we used to use vaginal progesterone in women with a previous preterm birth before 34 weeks, and we had 59 women. We have then asked Spanish group, Maria Goya and Elena Carreras, to give us the results from their study, but only on women who had a previous preterm birth, because that was the women that we were seeing. They gave us the results for 42 women, and then we had 142 from United States. So when we compared these 3 groups that were relevant to our Liverpool population, cervical pessary still looked the best. So we kind of had no choice, but in January, on the 1st of January 2012, having seen this data, we started to use Arabin pessary rather than vaginal progesterone as a first-line treatment. So we now have close to 150 Arabin pessary use, but those are the results on our first 82 that we have used. 62 with a previous spontaneous preterm birth, 20 with cervical surgery. 3 have fallen out, 2 have been removed on a patient's request, and 2 after clinical decisions because we have found a prolapsed membranes. When we compared preterm birth and cervical surgery, the results were pretty similar. And also when we compared our Arabin pessary results with our progesterone results, they were quite similar. So because Arabin pessary was cheaper and we could ensure compliance, where in progesterone we can't, we are still using Arabin pessary until evidence emerges that progesterone is superior or stitch is superior. But actually what we are now doing, because we are still not quite sure what is the best, so we are now participating in a randomized controlled trial where every woman with a short cervix is actually randomized to either cerclage progesterone or Arabin pessary. So we have now recruited around 70 women, and we'll probably need another 3 or 4 years carry on recruiting until we will know which of these 3 is the best. And now just briefly, few thoughts on a multiple pregnancy. Our NICE guidelines basically say that nothing works in twin pregnancy. And that is not very helpful to me as a clinician. So, when it comes to multiple pregnancies, in a systematic review of progesterone pessary or cerclage, there was 23 trials with 6,000 women showing that with vaginal progesterone, there is some reduction in the preterm birth rate and low birth weight. And also that, however, that with IM progesterone, there is no such thing. So one thing that we can actually confidently conclude that IM progesterone should not be used in a multiple pregnancies. Now, when it comes to vaginal progesterone in a twin gestations, there is a 31% risk reduction for preterm birth before 33 weeks. And so therefore, suggesting that a reduction of preterm birth actually goes from 43% to 31%, which is not an unreasonable and probably clinically important reduction. Okay, so the problem that we are now facing is that while vaginal progesterone in all twins have moderate effect, the benefit in a twin gestation with a short cervix is probably much stronger. And you can see here that in a short cervix, there is a reduction in perinatal deaths from 25% to 13%, and also significant reduction for 46 to 33%. So actually, current evidence seems to be suggesting that vaginal progesterone in twins with a short cervix may have some significant benefit. The problem with the cerclage in multiple pregnancy is that although the conclusion is that there is no evidence of benefit overall for any of the subgroups, the problem is that all this evidence is based only on 122 pregnancies, and this is just simply not enough to make any conclusions. So really randomized evidence is not adequate to tell us anything about the role of a cerclage in twins. There are some interesting studies talking about showing that potential benefit of cerclage in twins. One was published by Kypros Nikolaides and his group on 40 twins of cerclage and 40 controls, showing quite impressive difference in twins that were stitched. And also very similar study published from United States with 43 twins with a cerclage and 39 controls, also showing when the cervix is short, very short, less than 15 millimeters, benefit of stitch with twins. So we basically have exactly the same situation like we have in singletons, that there is a potential of all of these treatments to work, but which one of these is the best, and try to figure out which type, who should actually benefit from progesterone and stitch, remains to be a challenge. And so therefore there is no, unfortunately, there is no alternative but to carry on collecting the data and looking for the comparisons. And like in singletons, while we are debating whether to use vaginal progesterone or stitch, Arabin Pessary is also a new kid on the block, and there is a pro-twin study that actually has shown significant benefit in a subgroup of women with twins and short cervix. And that has been replicated by study from Spain. They also showed significant benefit when twins were given Arabin Pessary, but only when cervix is short. And that is, unfortunately, has not been replicated by Kypros Nikolaides. His team prescribed Arabin Pessary to all twins and found no difference whatsoever, but also disappointingly, they found no benefit in 240 twins who had a short cervix. So for some reason, Arabin Pessary in twins with a short cervix seems to be working in Barcelona, in Spain and Holland, but doesn't work in UK, which doesn't really make sense. May well be that there are some differences in the time when Arabin Pessary was on average inserted, because in Holland study, average Pessary insertion was around 19 weeks, whereas in Kypros' study it was nearly 23 weeks. And I think that probably makes sense. And this is certainly the reason why in a high-risk women, both twins and singletons, we start looking for the short cervix at 16 weeks. We certainly do not wait until 20 weeks. And in my practice, approximately 30% of treatments is initiated before 20 weeks because cervix is already short. So if I wait until 23 weeks, it may be too late. Maybe there is some issues with training, or maybe there is something else going on that we don't know. In order to try to resolve that, we are currently in the UK doing another trial for the Arabin pessary in a short cervix. Our plan is to randomize 500 women, and we are well on the way, so hopefully we'll have a result in next year. So, in summary, what we know? We know that obstetric history, cervical length, and quantitative fibronectin provide a good prediction of a spontaneous preterm birth. I think we can agree that risk-reducing treatments, both vaginal progesterone, cervical cerclage, and Arabin pessary, have been proven by RCTs in singletons when cervix is short. How do they compare with each other? That is open for the debate. However, we definitely need more randomized controlled trials and safety data to change clinical practice. What we don't know is how do we use this evidence to personalize the treatment, to apply it to individual patients. And what will be, so to understand what is the best treatment for cervix that is short but fetal fibronectin is negative, what cervix is short but fetal fibronectin is positive, that cervix may be short but vaginal microbiome is normal or abnormal. Of course, we need clearly better phenotyping, and we need more randomized controlled trials, not only in United States and the UK, but we certainly need them in places like Ukraine. The question is, who is going to organize and who is going to fund these clinical studies that we so desperately need? Thank you very much.
Dear Professor, thank you very much for your very structural and detailed lecture. There were a lot of very important issues were included in it. So that's why now we have a lot of questions. But I know that your time is limited, and if you are out of time, we will stop getting questions and say you goodbye and hug and kiss you. Уважаемые коллеги, мы сейчас сессию вопросов-ответов проведем, а следующие лекции сместятся чуть-чуть позже. Я перевожу вопрос Виктору Ивановичу.
Shall we start with induction of labor?
Mix. The questions are mixed.
Can I ask you, has anybody of you done outpatient induction?
No, I guess
Doesn't
no.
happen in Ukraine.
Victor, could you translate?
Скажіть, будь ласка, хто з вас проводить індукцію пологів? Підніміть руки, хто проводить індукцію пологів? А хто колись проводив індукцію пологів вдома, відсилаючи пацієнтів додому? No, they are showing reason. Я перепрошую, без мікрофона, на жаль, нічого не чути. Якщо нам хтось допоможе в залі, було б прекрасно. Well, people show, because, sorry, for the first, I didn't hear that you said outpatient. Yeah. So everyone raised the hand. When you said outpatient, a lot of people did like this. Meaning prison.
That's what I thought, yes.
So, yeah.
But, yeah.
But we have one brave woman. I know her personally from Rivne. She's very...
Доброго дня.
Добрий день.
Я дуже перепрошую. Ми в підготовці до індукції пологів широко використовуємо катетер Фолея. Ставимо 24-ку, 60 мл фізрозчину інтрацервікально за внутрішнє вічко. Таку жінку ми можемо, це не рутинно, але можемо, якщо жінка досить інформована і готова йти додому, ми їх відпускаємо додому. Через 24 години вона до нас повертається і залишається. Індукція пропонується на наступну добу з 6 ранку при біологічно зрілій шийці матці більше 6 балів за бішопом.
How many have you done?
Скільки ви вже зробили таких випадків?
Амбулаторних мається на увазі?
Так.
Ну, 30 і більше точно.
Well done.
Молодці, вами пишаюсь.
Дякую.
Yeah, we are even more crazy. We give. I told you we give prostaglandin. It's slow release. It's this tape that we use, Propes. And first 6 months I didn't sleep. I thought it was, I thought I was going to have a heart attack, but they are fine. And anyway, yeah.
But now we have a number of questions written. Okay, let's run. Dear Professor, could you please detailize the induction for labor, the indications for labor induction besides diabetes mellitus, IUJAR, and arterial hypertension?
Okay, the most common indication for induction of labor in my hospital is postpartum pregnancy, 41 weeks. So then ruptured membranes, then small baby, big baby, high blood pressure, low blood pressure, tall woman, low woman, short woman, anything. Women who are fed up, they can't cope anymore. I told you, we have 39% of our patients are being induced. So it looks like in Liverpool, if you cough or sneeze, you get an induction.
We have the next question. It's regarding what is the next step if a woman did not react for prostaglandin E2 or E1.
That's a very good question.
And it's a sub-question if it's possible to repeat the attempt of induction with misoprostol in low dosage, for example, in 24 hours.
I ran out of time. I have a slide as to how we manage failed induction. So if a woman is not in labor after 24 hours, we have a strict protocol what to do, and that depends on what is the initial method of induction. So for low-risk women, we are going to repeat prostaglandin for another 24 hours. For some, we are going to, for ruptured membranes, we will not. We are going to go straight to oxytocin. But in some cases, particularly high-risk cases, we may go straight for cesarean section if they do not respond after 24 hours. I think what I would like to say that what is more important than anything is to agree with the woman what you are going to do if the induction fails. It kind of almost doesn't matter what you do as long as you have a plan before that. What is the problem that we face time and time again, that women are being induced and they are under assumption that everything is going to be fine and they're going to have a baby in 18 hours. And then after 24 hours, nothing happens, and they cry, and they want to have cesarean section because nobody told them that there is a possibility that induction is going to fail, despite the fact that 40% of women are still not going to be in an active labor after 24 hours. So what we find, what we now try to do is that at the beginning of labor, we have an agreement, a contract with the woman to say, if after 24 hours you are not in labor, this is what's going to happen. And then there is no problem. In my practice, particularly in a low-risk women, say previous stillbirth, and then at 38 weeks, we decide that we are going to induce because woman is crying and she can't cope anymore. Then I will write in the notes, induction for 24 hours. If not in labor, go home, come back 3 days later, and we'll try again. And that's fine.
Induction of labor in patient with IUGR, indications and contraindications. Wide
Depends
topic.
what kind of IUGR we are talking about. My argument is that if we are good fetal medicine clinicians and you are absolutely 100% sure that you are dealing with a proper IUGR, you are a very brave person if you are inducing her. My argument is that if you are certain that this is an IUGR, then you should do cesarean section. The problem is that we are not certain that we are dealing with IUGR, so we are really talking about a small baby with a Doppler that may be a little bit like that, and then we try induction with a continuous monitoring, and then we have what is called a low threshold for cesarean section. First deceleration, oof, she goes to theater. So my answer to that, it very much depends on gestational age of your diagnosis and also whether IUGR is just estimated fetal weight below 10 centile, or you're talking about proper absent end diastolic flow, severe IUGR, in which case almost certainly you are not going to induce, but we are going to do cesarean section.
Thank you.
Just a second, we'll stop with. Ми закінчимо з тим, що є. I'm sorry, just two little sub-questions regarding the previous one. I mean, okay, we have IUGR, the baby is stable, multiparous woman, cervix score 8, whatever. I mean, very good, favorable conditions. You will not recommend induction? I mean, you will do cesarean section?
Just tell me how did you diagnose, what is the gestation?
It's small for, okay, it would, for example...
if it's small for gestational age,
30,
not IUGR.
36, 37.
But Doppler is normal.
No, we have elevated resistance in umbilical artery. We have elevated resistance in uterine arteries. And baby is small for gestational age, it's 5th percentile. Well, I mean, I understand that it could be different.
Professor is not impressed.
I have absent end diastolic flow, I have persistent end diastolic flow, and I have a CTG that is perfectly normal.
Yeah, that's another story. I mean,
yeah, I will. Computerized CTG is perfectly normal. To be honest, if I have persistently present end diastolic flow in the umbilical artery, that's fine. I don't care about uterine artery Doppler 37 weeks anymore. Cerebral blood flow is all over the place at 37 weeks anyway. So yes, I would, in this case, I would, if I decided need to induce, I think it would be reasonable to try and deliver vaginally. If I have absent end diastolic flow, which in my book is IUGR, everything else is absent end diastolic flow, no.
okay, that was another deal. Because I'm sorry why I was, let's say, so aggressive, because as for me, there was a statement, because of lack of time, we sometimes say some things which are really dangerous, because I didn't want people to understand that if we have real IUGR, we have to do cesarean section and not try vaginal birth. That is,
When we as a fetal medicine specialist, I really don't care about estimated fetal weight. I really get upset when clinical decisions are driven by estimated fetal weight. Estimated fetal weight is start of assessment, but decision how to manage labor and how to induce should be based not on the weight of the baby, but on the condition of the baby. Because there are babies that may be big, but they are not very well, and there are babies that are low weight, but are very, very good. And I think that to me is the key consideration. And so please do not go home thinking that I would do cesarean section for every small baby. When I talk about IUGR, I do not talk about weight.
thank you so much. Very valuable. Yeah, because most of children with IUGR who dies in Ukraine, they are not small for gestational age.
Well,
that is the question.
Yeah, well, if you do it that way, then I'm an IUGR person.
Okay, thank you. Next question.
I have the last one.
Okay.
What do you mean saying the low dose of misoprostol?
Low dose of misoprostol is less than 50 micrograms. So what I'm talking about, 20 or 25 micrograms of oral tablet. And I think that people who are using 50 micrograms, I don't think that anybody in their right mind would be using 100 micrograms or more. 50 micrograms in my book is already high dose. So low dose is less than 50 micrograms, i.e. 20 or 25.
I'm sorry, let me explain. So the situation in Ukraine, we have Cytotec. It's 200 milligrams. We cut it with a forceps. We put it in our pockets. It's always there. And
Cut it.
and we try to get to like 1/4, 1/8.
Yeah.
So what to do? I mean, what to do for Ukrainian?
How many of you are
doctors-
using misoprostol for induction of labor?
Тільки чесно.
And Cytotec, okay, Cytotec is 200 tablets. Cytotec is only 200. You haven't got to 100?
No.
Well, two things. I've been there. Try as a team to get it from, I think it's in Denmark or something. It is now possible to get tablets of 25 micrograms. They are now on the market. So please make every conceivable effort to get hold of, through your government or whatever, to a small tablets, because 200 micrograms cutting is not safe. If you want to do it, one trick that I have used is you put a 200 micrograms tablet in a 200 mils of water, you shake it, and then your patients can drink 20 or 25 mils. It works perfectly well. This is a titrated oral solution of misoprostol. That is certainly not perfect, and I wouldn't recommend it as a pharmacist, but I would certainly recommend it if your alternative is to cut the tablet in 8. But then we must insist to get tablets of 25 micrograms so that we can start inducing labor safely.
Колеги, з перекладом все добре, тому що це вкрай важлива інформація, так? Тобто, я вам скажу, ви всі прекрасно розумієте, що все одно ми купуємо Cytotec, який приведений контрабандою з Росії. Мало того, що ми підтримуємо країну-агресора, з якою воюємо, то давайте вже будемо... Фактично ідентична ситуація. Ставимо завдання нашим контрабандистам, щоб вони возили нормальний мізопростол по 25 міліграмів. Це є небезпечно. Неможливо втяти таблетку таким чином, щоб в 1/8 була необхідна кількість. Тому що розподіл по таблетці, по пігулці в 200 мг нерівномірний. І всі це прекрасно знають, які результати можуть бути після використання. Це вкрай важлива річ. Thank you so much.
And just to say, those of you who are using 50 micrograms or even 100 micrograms, you will love misoprostol because babies will be coming on a rocket fuel. But you will end up in trouble. Sooner or later, either uterus is going to rupture, particularly in a multiple, or baby is going to struggle. So just take it easy, go slow, and use 25 micrograms.
Thank you so much. Any more questions? So some more questions regarding induction. What scheme, what prescription should be of vaginal gel you use for labor induction? Do you use repeated gels? And if so, what is the break between usage?
Dinoproston gel, 2 milligrams 6 hourly, every 6 hours, as prescribed. Usually, 2 tablets, two dosages, 6 plus 6, and then you wait. And then after 24 hours, if nothing happens, then we review as a failed induction and have a discussion as agreed. Sometimes you can go straight to, I personally, because I'm old-fashioned, after 2 prostaglandins, I will always go for ARM and syntocinon, because if people cannot rupture the membranes after 2 prostaglandins, that there is something seriously wrong. But my juniors tell me that I'm old-fashioned, and then they may go after, in consultation with a woman, for third prostin after 24 hours. So you start at 8 o'clock in the morning, first prostin 6 hours later, second prostin, if there is no change, and then you wait until next morning, and then see what happens.
Thank you so much.
I have. This question seems to be important for our physicians because we have 2 similar questions from 2 participants. It is about simultaneously the time using of pessary and vaginal progesterone in the same patient for summarizing their effect.
Okay, so we've done induction of labor, now we can go on a preterm birth. Adding progesterone to Arabin pessary. I have no experience of it because we have always been comparing one or the other. Now, would I recommend it? No, because I have no data to support it. Does it potentially make sense? Yes, because mechanism of action is almost certainly likely to be different. But I would be interested to know, how do you decide who needs it? Or are you just saying everybody who has a short cervix, we are going to give both? Well, if that's what you are doing, keep collecting the data, but you will have to prove it to me that your results are better than those published with only one treatment. I can tell you what you should be expecting using either progesterone or Arabin. So you need to prove to me that if you are asking women to pay for both treatment, that you are doing much better than I do. And then I will believe you. I would be interested to know what phenotype are you using, what criteria a woman needs to qualify for you to say, oh, you need both. Or do you just sort of think, yeah, it's Monday today, so I'm just going to give her both.
Thank you so much.
And on Tuesday, I'll give her only one.
Okay, thank you. We have much more questions that. Okay, but I think that я думаю, колеги, да, що ця сесія дуже важлива, як на мене, тому ми трошечки затримуємось і, можливо, внесемо певні зміни. Всі доповідачі хай не турбуються, ми всім дамо достатньо часу. У нас ще є запитання по індукції. Да? Повернемось. We'll come back to induction. We have a question to Telegram. Do you use mifepristone for labor induction?
No, there are some
Барабанная дробь.
interesting data, but we have the trials have been largely negative. There has been some worry about possible side effects. The reason, and this is why it has been withdrawn by the company, and they wouldn't let us do the placebo-controlled trial when we wanted to do it. But if you guys have experience with mifepristone for induction of labor, can you please show me the data, because I would love to see them.
I'm sorry for interrupting. There is an RCT from Russia published in the European Journal of Obstetrics and Gynecology. This last year. So they have an
Or maybe I
RCT.
missed it. How many patients have they done?
I can't tell you.
Good trial?
Yes. Yes. I mean,
Placebo-controlled?
Yes.
And they say that it works?
Yes.
And safe? Okay.
No, just, I'm sorry. Just, it's good. It works.
Okay. It's
About safety, there was nothing there. I'm
Sorry,
sorry. It's very important. The question that it works, it seems to work.
But it's
It
not.
definitely works in dead fetuses, but we don't know anything about alive
And they
fetuses.
compared it to what? What was the comparison? Was it nothing compared to placebo?
Анна,
I think it was compared to placebo.
Yeah, but okay. I mean, I'm sorry. I need to look at this study. But when I decide to induce, then I can't give a woman a placebo. If we are talking about mifepristone as an induction, my understanding is that the comparison should be a prostaglandin or cooked catheter.
I might be mistaken, I'm sorry.
It cannot be cup of tea.
Yeah. I'll have to look up at it. It's just not.
But I haven't seen a studies that I would be, but I would be interested to see a comparison of. I think it is important that we are clear what we are talking about. There is a comparison of treatment versus expected management. When you are, I mean, we talked about estrogens, and when you are kind of trying to ripen the cervix. That's not what we are talking about. I'm talking about you have made a clinical decision that baby needs to come out. What are you going to use? That to me is induction of labor. Cervical ripening or preparing woman to induction of labor is a separate clinical issue.
Thank you, Professor. And we have two more very short questions regarding the number of induction failure in your clinic, and just few words about cesarean section rate after induction and average level.
I've told you after 24 hours we have approximately 30% of women they are not going to be delivered after 24 hours, and approximately 5% are not going to be delivered after 48 hours. So yes, there is a failure rate, and as we've discussed, management or how we manage failure depends on the reason for induction. And if you have a low-risk induction for social reasons, for example, then it's perfectly reasonable, as I said, is to send a woman home and a repeat induction 3 days later. Now, clearly, if a reason for induction is an IUGR, then you may say after 24 hours, cervix is unfavorable, baby needs to come out, or preeclampsia, then you may actually do cesarean section. going back to, and the second question was a cesarean section. I don't know about you, but we as an obstetricians find it impossible to believe that induction of labor does not increase cesarean section.
That's a religion in Ukraine, that induction
that
of
is-
labor raises the cesarean section.
That has been my
Just for you to
religion.
understand.
Yeah, and I was certainly part of that church for 30 years. The problem is that we have always compared induction of labor with a spontaneous onset of labor, right? So if you actually look at 100 women who have been induced, that we have induced, and you compare it to 100 women who come into spontaneous labor, of course our impression is right. Women with induction of labor are going to have more cesarean sections because they are higher risk. Okay? And that was our religion for 30 years. The problem here is that if you take, apparently, 40 weeks, small for gestational age baby, and then you induce them, and then you compare it for gestational age baby that you leave for another week, by which time it may be even more small and less likely to sustain labor, the evidence seems to suggest that if you leave these high-risk women for another week, you may end up with possibly more cesarean sections. So there is trial after trial after trial comparing women who are, so the comparison here is you as a clinician have made the decision that woman needs to be induced. And then you say, I'm not going to induce you, I'm going to leave you. Because I'm going to leave you so that you can have less cesarean sections. That doesn't work. If we leave them, they end up, if anything, possibly even with more cesarean sections. Either because babies are bigger, so there is more dystocia, or babies are sicker, and then 2 weeks later cannot sustain labor. And when you think it that way, which to me was anathema, then it kind of makes sense. So, if you ask me, should we be inducing everybody at 39 weeks? Absolutely not. But if a woman now comes to me at 39 weeks, and it's August, and it's plus 40 degrees, and she can't sleep, can't eat, has a lot of hemorrhoids and varicose veins, and say, doctor, can you please induce me? 10 years ago, I would say no. Now I say yes.
Thank you. Great answer. We have more questions, some more questions, and we will definitely come to you. I mean,
Preterm birth. Could you please explain the using of fetal fibronectin, how to detect and how to interpret the data?
Okay, fetal fibronectin, we in my clinic are using it for the research purposes, but there is as you know, a vaginal swab fetal fibronectin qualitative, but there is now also quantitative assessment test, and if you put in your app store, Quip, QUIPP, you can download it now, free of charge. It was produced by Andy Shannon and his team in Thomas and St. Thomas's, and it tells you whether you are symptomatic or asymptomatic, and you can put cervical length and the quantitative fibronectin value, and it'll give you the risk of preterm birth for this particular woman. What you do with this risk is your problem. That's how it works.
Thank you very much.
Я буквально короткий коментар стосовно фетального фібронектину. Два моменти. В Україні з цим погано. Є принаймні дві можливості, якщо ви хочете використовувати. 13-14 рік ми робили в перинатальному центрі. Завідувачка лабораторії знає, як робити, знає технологію. Вартість була, ми розраховували приблизно 110 гривень, $1 по 8. Тобто, вважайте, десь приблизно $12-14 одне обстеження. Купувати треба одразу велике пакування, тому там питання стає вартості для державного закладу для саме кількісної оцінки. Але не тому, що синтез підтримує доповідь мою з писарів, а тому що, наскільки мені відомо, вони єдині, хто мають зараз сертифіковані вагінальні тести на фетальний фібронектин. Потім підійдете до них на стійку, вони вам розкажуть. Тобто ми їх використовуємо в своїй практиці. Це, звичайно, тест полоска, тест смужка, яку ви можете... Є чи нема? Тобто наявний фетальний фібронектин в виділеннях чи ні? I just told where you can find it in Ukraine.
The last one, preterm birth. It was mentioned at our first day of our meeting that the using of pessary and bed rest is useless. Should we use these two approaches? Yes, it was mentioned in one of the talks. I remember.
Okay. For the
I think that it is about some trials which were.
Well, yeah, there are Kypros. In Kypros's trial, it was useless. In Spanish trial, it was absolutely miracle.
It's controversial, controversial.
So the question is, which one do you believe? The issue with Kypros's study, as far as I understand, is that all women who had a very short cervix, less than 15 millimeters, were treated with progesterone anyway. So you could argue that ability for Arabin Pessary to do good was somewhat diminished. The jury is out on Arabin Pessary in singletons. There is no question about it. But the good news is that there are many, many trials that are currently happening, and there is going to be many more sort of pooling of the data, this individual patient data analysis, within the next 2 years. So I would say, let's reserve your judgment for Arabin Pessary, or Pessary at all, for the time being. And I think that based on current evidence, progesterone, if you have to have a choice of one treatment in singletons for short cervix, particularly in a women with previous preterm birth, then the evidence is by far the strongest for progesterone. And for Arabin Pessary, I would say that jury is still out. For twins, I think that the data are really, really encouraging. Again, we need to keep an eye on what's happening. So that is official statement. If you ask me what you should be doing in your clinical practice, while these data are emerging, for women who have a previous preterm birth, who are high risk, I urge you to start doing cervical screening at 16 weeks. Don't wait until 21, 22 weeks. Keep an eye on the cervix, and if it's going below 25 millimeters or below third centile, you should treat it for women with that are high risk. What do you treat it? At this stage, almost doesn't matter. If you are passionate and good surgeon, you want to put stitch, I can't object to that. If you are in outpatient clinic and have a difficulty arranging cervical cerclage, particularly because women can't pay it, please give her vaginal progesterone. And if you want to go for the cheapest option, go for Arabin Pesra. And I think that all of these treatments at the moment are reasonably evidence-based, and that there is very little to choose between them. That would be my interpretation of the evidence for practicing clinician.
Thank you very much. And the second part of the same question was about bed rest. It seems to be important. Does it make sense to use it if we have some results of meta-analysis that it is useless?
Okay. When I really want to be nasty, then I say, well, if you prescribe a bed rest, then you might as well prescribe Fragmin or Deltaparin to make sure, or low molecular heparin to make sure that woman doesn't end up with DVT. My question would be, if you, for those of you who prescribe bed rest, how do you prescribe it? What does it mean? 23 hours in bed and only to toilet? Or how does this, what is this prescription called bed rest? How does that work? When you give progesterone, I know because I can see. I know what stitch looks like, but I don't quite understand how the bed rest works. And is there, out of these four, I think that the evidence for bed rest is the weakest. I'm concerned about that I'm going to give women a DVT. Anyway, I've stopped there.
Thank you so much. We have 2 more questions, and that will be the end. Okay?
There in Europe, there was presented this artificial laminaria-like stuff. What have you heard about it? They presented it as a good option for home inductions. So instead of laminarias, they made some synthetic sticks and.
These are hygroscopic, and then they have. I have no experience of it. We use if we go for mechanical induction, we use a Cook catheter. I have to say that people who use the mechanical methods think that they are fantastic. I kind of, anyway, this sort of gel or tape seems to be kinder to women, and I feel more comfortable. But apparently women who have these things coming out, they are fine. So they tell me. But yeah, no. Is the answer
And
to that.
the other question is about Brito. It was a feeling, but I think now there is an article in White Journal that ART twins, they are much less predictable. When you measure the cervix, you can't predict the situation.
Sorry, which twins?
After artificial reproductive technology.
Right,
And
okay.
they are a big part of all twins now. So maybe to exclude them from such trials or to make separate calculations, separate analysis.
I'm struggling to think why would progesterone or Arabin or Seclage be different in dichorionic twins just because they have been conceived by embryo transfer or whatever. I don't know, and I would be interested to keep looking at this data. In my practice, I make no distinction between twins that are I don't pay much attention as to how they were conceived, to be honest. But I could be wrong, and I'm sort of thinking, I could think how my treatment could be informed by maybe knowledge of vaginal microbiome, or fetal fibronectin, or some sort of objective biomarkers, or even we have some data to show that previous history, where the previous preterm birth was ruptured membranes, pre-labor ruptured membranes, or spontaneous preterm birth. That to me is important. But just to say that the treatment should be different, depending on a type of conception,
No,
is...
I can't say the different can be different. We don't have so much options, but the results might be different.
Yeah, okay, but in terms of what we're talking about, how to manage them, how to treat them, you know, if the cervix is dilated, then you need to deal with it irrespective of the conception, I would say.
Thank you very much. There is a question, I can't read it actually. Maybe the author will read it and Victor will translate it.
Давайте я спробую.
Esteemed professor, з якою частотою ви призначаєте 25 мікрограм мізопростолу для індукції пологів, без преіндукції? Годину, що 20 хвилин?
Orally, every 2 hours.
Перорально кожні 2 години.
Thank you very much.
Slow. 25, 25, 25. Just keep doing it every 2 hours.
Thank you very much.
And of course, if she is contracting strongly, then this is what we talk about titrating. Now, if you have say primip with a very long cervix, and you give 25, 25, and then nothing happens, then you can give 50. That is titrating. You know, after 2 hours, but always wait 2 hours to see what the response is. And then if she's contracting very strongly, then nothing. And then it's just as an obstetrician, just sort of like oxytocin, up and down, up and down, up and down. It works.
So if the contractions go down, you just add
You
25
I would, yeah.
during the whole first period of labor.
I would certainly. That we don't know yet. We are now doing the trial, actually planning the trial in India, where we will be doing misoprostol, comparing misoprostol to oxytocin all the way. At the moment, I would not recommend using misoprostol all the way, because that is particularly at 8-9 centimeters to give an oral misoprostol. We don't have enough data to say that this is safe. So this protocol goes until she's sort of 4 or 5 centimeters when you're in active labor. Then if she needs something at the moment, I would go to oxytocin, swap to oxytocin. This is kind of still for induction of labor, but it may well be that with experience, we may go with misoprostol all along. The problem, but what you then need to be ready, please, that if you are using this misoprostol, you need to be ready to give terbutaline, tocolytic, because we use that all the time. If there is, because when you give misoprostol, particularly multiple, you will have hyperstimulation. And then CTG is going to go down, but no panic. Just the butylene, and it's going to be fine. So you need to have, absolutely, you need to be walking around with the 250 micrograms of the butylene. And we give it like chocolate all the time, if we are worried about the CTG. Because it would be disaster to then do cesarean section just because baby is slightly decelerating because of hyperstimulation.
Professor, thank you. It was a great job, this QA session. And can I ask you one question personally from me out of this topic? All of us know that you are an author of very famous meta-analysis about third trimester ultrasound and about uselessness of its performing. But yesterday I had a talk with Luc Descartes, for example, and I was told that there in Belgium they have this, they have a national policy and they have this scan, routine third trimester scan. Could you please answer honestly, dear professor, if your own wife is pregnant now, or your own daughter, would you give them a piece of advice to undergo the third trimester ultrasound or not? Can
Okay.
shortly.
Can I just apologize and say that when it wasn't actually me who did this meta-analysis, but it was published in the Cochrane, and when we say that there is no evidence to support third trimester, routine third trimester ultrasound, that doesn't mean that routine ultrasound have no value. What it means is there is no evidence that it works. So can I answer your question by asking you a question? If my daughter is 26 years old and not yet pregnant, and she hasn't got a boyfriend, but she will, hopefully. And if she says to me, Dad, should I have a third trimester ultrasound? And if I say yes, and then she asks me why, what are you going to achieve, Dad, by doing this scan? I will do the scan because I'm a fetal maternal specialist, but just explain to me, what shall I tell her? Why am I doing the scan? What am I, because if I give progesterone to short cervix, we will reduce preterm birth. When we put a stitch in, we are going to reduce preterm birth. When we induce labor, we are going to reduce perinatal mortality. So if in a fit and healthy young Ukrainian woman who eats well, baby is moving, her abdomen is like
Is
this.
growing up.
And at 36 weeks, she needs to pay 30 euros. How much does she need to pay for a scan?
Here in Ukraine,
yeah.
it depends on regions, on clinics. I
Ballpark.
don't know, not so expensive as you say.
Ballpark,
yes.
20 euros. 40 euros.
Much
20
cheaper.
euros. Okay, 10 euros.
Okay.
So if she needs to pay money,
Okay.
why is she paying money? Just what do we tell them? Why is she spending money? Are we reducing the risk of stillbirth?
Not risk of
Are we
stillbirth,
reducing no? Are we reducing cesarean section? Well, that is so. Yes. So that is my evidence-based answer. Is that we have no evidence that third trimester ultrasound reduces any of the important outcomes for fit and healthy young women who need to pay money. Do I, as an obstetrician, try to find an excuse to do ultrasound because I don't believe anymore my hands? The answer is yes.
Okay.
But that is different from saying that every woman in Ukraine must have third trimester ultrasound, because we would then have to have a firm evidence that it causes some sort of significant benefit. And I'm just going to finish and then I'm going to shut up. If we are going to offer this ultrasound, and if you ask me personally, I think we should, but only with one provision, that people who do ultrasound know what they are doing. The reason why I'm not keen to recommend the routine ultrasound, because I am worried that people are going to do serious harm, because I have seen finding a borderline ventriculomegaly, which was not, some funny things on kidneys, which they are not, oligohydramnios, that it's not, doing silly cesarean sections for ultrasound findings that are wrong. So I would say that in a low-risk population, it is a serious concern that people who are not well trained are going to find, with good ultrasound machines that we have, really silly things that are of clinically no consequence and are going to start doing things to women that are going to cause huge harm.
Thank you very much. Difficult question and controversial. Do you agree?
Можно еще?
Thank you, Zarka. We hope very strongly that you come back once.
Разрешите еще два коротеньких вопроса к индукции вернуться. Простите. В январе...
Let him.
Yeah, well,
Thank you.
look,
В январе...
I'm fine. I can be here for another 2 hours if you want.
Okay.
В январе
But other
2018
people need to
года.
talk, so I think, Victor, are we okay? I think we should stop. Victor.
Victor, we missed.
Please, yes, and we have to stop. Thank you so much.
Уважаемый
It was a
профессор.
real pleasure, but we finished now.
В январе 2018 года на ресурсе UpToDate был опубликован обзор по индукции родов, и где, как хорошая практика, показывалось использование катетера совместно с мизопростолом. Как вы к этому относитесь и был ли у вас такой опыт? И второй вопрос, все-таки вернуться мифепристон. Да, действительно, как бы нет таких хороших данных по использованию, но мифепристон мы используем в 2 года вот у себя в лечебном учреждении мифепристон с целью преиндукции родов, созревания шейки, и имеем неплохие результаты, на что ссылаясь на рекомендации ВОЗ, которые были по индукции опубликованы. И у нас есть проект клиничной настановы, уже 2 года, и никак она не принята, но там тоже есть рекомендации использовать для преиндукции. Если нет убедительных данных по эффективности, то, может быть, есть убедительные данные по, наоборот, вредному воздействию мифепристона, где, может, нам не надо использовать его для преиндукции.
The question is about using of mifepristone for pre-induction of labor and about catheter of Foley in combination with mifepristone.
As I told you, I really have no experience of mifepristone for pre-cervical ripening. I understand that there has been some recent randomized control trial. I'll have to look at this evidence. We personally have no experience with that, we use mifepristone a lot for in combination with misoprostol for termination of pregnancy in the first trimester, and also for induction of labor with intrauterine death. But we haven't been using. I have no experience in using mifepristone in women for induction pre-cervical ripening with a live fetus. But if there is any, but I will keep an eye on that. So next time when I come here, we can have a more informed discussion about it. But I will certainly look for the evidence to see whether this is something that we should be considering. So I'm sorry that I can't offer you any insight in this topic.
Thank you very much. Thank you, dear Professor. We appreciate a lot all what you did for us, your participation, your job here in this question and answer session, and we hope for your coming back here in Kyiv on time.
Thank you, Professor. Шановні колеги, у нас буде 40 приблизно хвилин затримки, але я